Dear colleagues, dear friends attending us on the other side of the net, I feel extremely happy to be chairing this session today, this live webinar that happens to take place on 17th of September, which is the day we celebrate worldwide the patient's safety. Our topic today is related to the personalized pain management with the nociceptive NOL index and the role of regional anesthesia and how we can utilize it. And I have to admit that, first of all, I have to introduce myself. I am Eleni Moka. I come from Greece. And I have the great honor and privilege to share this session with two great colleagues, Dr. Andrei Perciun from the UK and Dr. Andrea Luigi Ambrosoli. I will start with a small introduction in relationship to the topic, and then the two next presentations will follow. However, please feel free to send your questions, your comments in the Q&A box that is available throughout the webinar. And at the end of the talks, we will discuss the topic altogether. Very briefly, I have some conflicts of interest, although these are not related or do not influence the content of my talk. And directly entering into the topic, when we discuss about perioperative acute pain, the pain we have throughout surgery, I would dare to say that we discuss about a silent epidemic. Why? Because it seems that inadequate pain control, it's the rule rather than the exception, as we have read many times in the conclusions of John Bonica, the father of pain medicine, one of the most important people that have devoted his life to the research of pain management and treatment, and who concluded that for more than 20 years he had been studying the causes of inadequate management of perioperative pain. And each time he arrived at the same conclusion, that the most important causes, unfortunately, still remain the same and include the inadequate or incorrect application of the available information, as well as the unsuccessful adoption of available therapeutic techniques. And when we discuss about unsuccessful adoption, one could mean lack of organization, lack of structured services, and of course, lack of available monitoring of the analgesia that we offer to our patients. And it is true that in the perioperative environment, with a very big number of surgeries and ICU hospitalization days that have been reported worldwide at an annual basis, unfortunately, more than 50% of our patients experience severe postoperative pain. A large proportion of them, that may vary according to the operation, develop chronic pain after surgery. 6% develop opioid dependence, and even more sadly, the cost of treatment of opioid-related adverse events in the surgical patients can exceed the 20 billion in the US alone. So we see that we have an important problem. And if we see more closely to that problem, we can immediately understand by an untreated perioperative pain, we can have impaired physical function of our patients, dependence, extended recovery times, and the persistent post-surgical pain, which all of them have great economical costs and an impact on the quality of life of the surgical population. And it is true that sometimes it is our mistake or our misunderstandings, because it is not possible that one size fits all our patients. This is not the case even for the analgesia itself, because we have a great interpatient variability in the analgesic requirements. Not all patients remain in the middle in the middle of the area under the curve, as we have extremes. We have elderly patients, we have obese patients that necessitate a different approach. However, unfortunately, sometimes in our practice we are not so successful, And we often result in either underdosing our patients, meaning we underuse the available analgesics that we have in our hands, with all the consequences like hypertension, tachycardia, severe pain, CNS sensitization, and so on. Or other times we use excessive dose of opioids. And we are all aware of the adverse events that are very detrimental for our patients, but both underdosing and overdosing finally can result to delay recovery and complications. This is why, even in the perioperative pain management field, the precision medicine model that was introduced 10 years ago in the United States seems that it has a place. And what is this precision medicine? It's a new era of medicine taking into account individual differences in people's unique biology, environment, lifestyle, empowering patients, researchers, and providers to work together toward development of individualized care, which seems to be a case of great expectations, as it has been written in multiple articles in literature. Why this precision medicine? Because the best available evidence for an individual may not always be the overall group level answer that is derived from the synthesis or the meta-analysis of interventional studies, because this analysis cannot always take into account all patients' individual characteristics, as it has been written in this very recent daring disclosure published in RAPAM in 2024. And as far as the role of regional anesthesia, yes, it plays an important role in fast-track surgery, in early mobilization of our patients. It is an important element of the ERA's protocols, and truly it has transformed the perioperative care. However, even with regional anesthesia and the management of acute intraoperative or broadly speaking perioperative pain, we can have a lot of challenges. First of all, the effectiveness of the block could vary. Why? Because even with the ultrasound guidance, the blocks can be incomplete, could wear off during surgery, or miss secondary innervation areas. And sometimes, unfortunately, we only discover this very late when the patient shows the strengths, responses, and characteristics. In addition, even if we apply regional anesthesia, we should never forget that RA is a part of the multimodal analgesia protocols and strategies, which are extremely essential for treating the acute intraoperative and postoperative pain for our patients. Patients, we should always remember, that require balanced analgesia, and titration is often imprecise. In addition, even with RA, we can have interindividual variability, meaning that without a reliable way to monitor nociception, we continue to either over or underdose our patients as far as the analgesics that are administered, and which are working as adjuncts to the RA techniques that are applied. And of course, we have not managed with regional anesthesia to prevent persistent post-surgical pain, unfortunately, until today. Furthermore, there is always something that is very important not to forget: the analgesic dilemma. Is there any pain that is felt while the patient is asleep? The answer, of course, is yes, and we have to remember the difference between pain and nociception. Pain is the patient perception of injury, and pain affects the whole body, as we all know, and not just the conscious mind, whereas nociception is the physiological response to the surgical injury. And even if we have unconscious patients, the body continues to respond and remembers the pain that is felt throughout surgery. In this context, it has been clearly written in literature that adequate intraoperative nociception management is extremely important. and it can result in improvements in postoperative pain management as far as 12 months after surgery, as it has been concluded in this very nice study involving 61K patients. And according to the authors, contrary to prevailing trends, the reduced opioid administration during surgery may have the unintended outcome of increasing postoperative pain and postoperative opioid consumption, and conversely, improvements in long-term outcomes may be achieved by optimizing the opioid administration during surgery, a conclusion that has been strongly embraced also by the Anesthesia Patient Safety Foundation, as it was written a couple of years ago in one of their documents and newsletters. So it is very obvious that we need an adequate intraoperative nociception management to improve outcomes. The question is, how are we going to achieve this? Because it is true that we have, as anesthesiologists, to jump to pass by a variety of disclosure hoops and loops. Why? Because anesthesia is not just a simple action, it's actually a balance between three important, let's say, entities. First of all, the immobility of our patients, the unconsciousness, of course, the sleep, that we know with which drugs we can achieve those two, but also of the analgesia that can be achieved by various analgesic drugs that we have in our armamentarium, but also by the regional analgesia techniques. And the challenge is how to reliably assess the intraoperative nociception. And why this is challenging? Because until recently, nociception was assessed indirectly through changes in heart rate, in blood pressure, or in other physiological parameters. However, those parameters and clinical criteria have poor sensitivity and poor specificity to detect the nociception level during the whole anesthesia course, and could result to either excessive or insufficient analgesia at the very end. And the big question is how we can complete this missing piece in a full anesthetic course. The solution is probably by applying a multimodal monitoring. We had the TOF, the pulse oximeter, the bispectral index, and since 2020, we also have monitoring of nociception, which is extremely useful and important of all of us. And the first FDA-approved AI technology to quantify pain can happen through the PMD-200 device, the first and only pain measurement device for anesthesiology authorized by the FDA. It utilizes AI technology that captures the signature of pain using multiple calculated physiological parameters. It offers an AI-powered pain response scale from 0, that means no pain response, until 100, where we can have extreme pain conditions. Plus, it's non-invasive. It utilizes a probe in the finger and a single-use sensor that acquires multiple pain-related physiological signals that are analyzed via a razor blade business model. And it is true that this monitor is multi-parametric, taking into account major families of criteria and parameters like the temperature, the galvanic skin response, the accelerometer, the plethysmograph of pulse rate, and pulse rate variability. And if we want to look a little bit more closer how exactly this works, this monitor, this non-invasive platform, continuously acquires physiological signals through the 4 sensors, and dozens of physiological parameters and derivatives are extracted. Those are analyzed via advanced AI algorithms to identify the pain-related pattern, and the information at the end is quantified and visualized with NOL, with a NOL index on a scale, as I said before, from 0 until 10. And based on the value we receive and see on the monitor, then we can be guided as clinicians to offer to our patients the optimal pain care. As far as the indications for use, this monitoring is indicated in a clinical setting that first of all requires assessment of changes in nociception levels in adult patients undergoing general anesthesia, receiving opioid or opioid-sparing analgesia as part of their care, and this is applied in the United States as an indication, whereas in Europe we can say we are a little bit more liberal in the application of the monitoring, utilizing it in settings that requires assessment of changes in pain levels during a medical procedure, like monitoring the patients under anesthesia, under surgery, in postoperative recovery, physiotherapy, application, pain tests, etc. What is important to remember is that this monitoring should be used by professional anesthesia providers, not as a single monitoring alone, but as an adjunct to our clinical judgment, and should never be used without the supervision of licensed healthcare practitioners or providers. When we interpret the NOL trend, we should always observe the trend line at least for 1 minute before responding or deciding what to do. We should remember that we cannot anticipate noxious stimuli, and thus minimal levels of analgesics should always be maintained and should not be used to guide us in the offering of preemptive analgesia prior to emergence. The values that we should target should be between 10 and 25, because below 10, it means after 1 minute, it means that we have excessive anti-nociception, and probably we need to reduce the doses of the analgesics we offer to our patients. And above 25, it means that we hypotreat the analgesia offered to the surgical population that we are dealing with. It is true that the FDA is the first organization that recognized this monitoring as a spotlight, I would say, as the first nociception monitor for use in general anesthesia, but we can use it also in cases we apply regional analgesia techniques to our patients even while asleep. And the clinical value is multi-level. It can help us improve postoperative outcomes because we can have pain reduction in the PICU and the reduction of the opioid consumption again in the PICU. It can result in a reduced variability in anesthesia care, offering personalized care per patient, per each patient's needs and according to surgery. It can help us titrate the analgesia that is administered safely, especially in high-risk patients. It can support multimodal analgesia and opioid-sparing or even opioid-free regimens, and of course to confirm the regional analgesia blocks. There are multiple studies with promising results in literature, in open heart surgery, in thoracoscopic surgery, in VATS, in knee arthroplasty, even in the pediatric population, but I will not analyze the results as we have the next speakers. And what I would like to focus is that until now, we were thinking what happens until the moment of surgery and anesthesia. However, it seems that when we discuss about precise perioperative analgesia, when we are successful, the results become evident and apparent in PICU, but even beyond when we discuss on the overall outcome of our patients. It is obvious that we have a new paradigm shift in perioperative pain management. This is the precision medicine model, because we have moved from the one-size-fits-all medicine further to stratified medicine, which has been left behind us. And we go now to precision medicine that utilizes at the individual patient level various parameters and various entities: genomics, omics, lifestyle, history, records, biomarkers, biosignature. And the important thing is that when precision medicine is integrated in perioperative pain management, it ensures delivery of the right analgesic to the right patient at the right moment for the right procedure. And definitely, NOL index has a place here due to the specific AI algorithms that are involved and that can help us offer the best possible treatment to all of our patients. We know that the precision, personalized, procedure-specific analgesia is probably the future in the perioperative analgesia regimes that we apply to our patients. Regional anesthesia is an integral part of all this concept. Of course, we cannot affect always the patient factors or not in total the surgical factors as anesthesiologists, but we can definitely have an impact on the ERA's protocols and their outcomes. And of course, with our action and our monitoring, help have a multidisciplinary team support and approach. We can have a dedicated pain relief result. And of course, NOL can be involved maybe in the future in protocols that could minimize any disparity that is offered to our patients. And to conclude, I would like to just leave you a take-home message that every patient needs measured treatment tailored to their needs, that the NOL index is a very promising tool in our hands as it offers objective pain levels measurement, and possibly that this type of monitoring could have many perspectives from the future that could include its role in teaching, in research, in improving our patients' quality of life, mainly by facilitating and achieving the outcomes of ERA's protocols. And at this point, I would like to thank you for your attention and to continue with our next speaker, who comes from the UK and is Dr. Andrei Perciun, who will share with us his clinical experience by utilizing the NOL monitoring. Thank you very much. Andrei, the microphone to you.
Okay, so my name is Andrei Perciun. I'm presenting Essex Cardiothoracic Center in UK. Center, which is on the eastern coast of UK. So our activities you see in last year was over 700 cases for thoracic and cardiac surgery. We have some interventional cardiology as well, many other components here. So to be able to share our experience, we decided to make a smaller pilot study, which was a compound from two main pillars, which is a deep parasternal block, which we use here, and going for general anesthesia in cardiac surgery, but it is a NOL-directed anesthesia, using the NOL monitoring, trying in this way to find if we can match the requirements of ERA's protocol. So we enrolled 20 cases, from which 5 case dropped because of some issues, some technical, some learning curve, some took a bit of time. Totally, we assessed 15 patients, 6 cabbages, 4 AVR, 3 MVR, 1 Bentel, and 1 David's procedure. So average age was 70 years, and youngest one was 45 years old, gentleman, experienced in David procedure. So we did 14 deep parasternal blocks, and just 1 patient had a superficial parasternal. So we know this protocol of ERA's protocol, which is suggesting us that the multimodal analgesia should be applied in cardiac surgery as well. And one of the part of this protocol is regional anesthesia. And as well as a recommendation, we see that it's utilizing opioids in a judicious and target fashion. What means judicious? It can be treated differently. So still, we say that the anesthetist is free to use his expertise on administration of opioids. So still, we don't have very precise, let's say, recommendation for this. saying that we know that there are quite large impact now with many researchers and articles coming to suggest different blocks, different approaches, some of them more efficient, some of them less. It's still a kind of research and trying to find the best approach. Anyhow, the impact is definitely positive. I think what we use here, as I said, deep parasternal block, we're using bilateral on space T2, T3, and T5, T6. If you look anatomically here, we'll use in the area where the intercostal nerve is still quite far away from the margin of the sternum. So being away from the vascular mammaries vascular area, and we use transverse approach. As we see, the probe is covering partially sternum and partially is on the chest. So technically it looks like that. So we find with the probe a sternum in a sagittal position. We have a white line which is telling us about sternum. We move a bit laterally where ribs are coming in our view. Then we have a margin of a sternum with a vascular pack here next to a sternum. You go a bit more laterally, opening well an intercostal space. So being quite aware, you see on this picture here, a needle is coming down, and we see a sausage of our local anesthetic, which is spreading over there. So on this video, I'll comment quickly. This we see sternum margin. We'll use a Doppler to identify vessels. So you go a bit more laterally, and we come with a needle from lateral side under the intercostal complex about the thoracic transverse muscle, and you see how the local anesthetic is spreading medially and laterally to cover all shaft of intercostal nerve. For CABG patients, we found that even if you do a parasternal block, a patient is responding when you start harvesting veins and having some peaks on a NOL monitoring. So we decided to do an adductor canal block. So finally it looks like that. You see 4 injection in area of sternum and an adductor canal block as well. So we use between 1.7 to 2 milligrams per kilo of levo with a concentration of 0.375. If you need a bit more volume and you see that you can't cover all space you need, we have some big patients, sometimes obese patients, some etc. We can dilute to 0.3 in this way to respect the dosages which is safe for our patient. So now in this situation, when we know about medication, we know about blocks, anyhow, these researchers we spoke, they are giving us information about the benefits of blocks for post-op pain control, not saying too much about how we manage patient intraoperatively. So the question is, you do a block and you expect these benefits, we know about them now in post-op, but how much we give opioids intraoperatively, how we manage patients, where is a safe reality for us, we need to keep our patients safe. So the answer is the NOL monitoring. If you do a block or you don't do a block, NOL monitoring is allow you to assess nociception of a patient. You know already about how we quantify it. So this is guiding us to know exactly when and how to do it. So now if you look on this picture, we have all this monitoring. We have cardiac, respiratory, we have BIS monitoring, we have oxygen, brain oximetry, and we have finally an NOL monitoring. So we call this situation now anesthetic cockpit, which looks quite informative for us. So now I'll present you some information about 3 hour cases. So we use the 13 time points to assess patients on multiple parameters from arriving to theater to arriving to ICU. You have here induction, AT-tube place, you have a knife to skin. If it's not a sternal area, it can be a groin, can be a leg, a knife to chest, we have sternotomy, aortic cannulation. When you go to bypass, we stop NOL monitoring. Then when we come back after 10 minutes, patient hemodynamically is optimized, we restart. NOL monitoring, and we can see what's happening with patient after bypass. So we can see what's happening if it's decannulated aorta, virus, etc. So here on this slide, you see on top a case which is a classic approach. Let's say traditional. It's still in place in some anesthetics or some places where it's not generating a pattern. It's quite a real one. So you see all of this point time like induction, tubing patient, skin incision, sternotomy, aorta cannulation, and totally cumulative dose on this case on top, patient who had cabbage-free grafts, had 1,200, more than 1,200 micrograms of fentanyl. Second case, a bit lower here, it's a cabbage-free grafts. And I need to mention here that, as I said, we do a ductal canal block, but for this patient, when we finish blocks, so we've been told that they'll harvest veins or another leg as well. So it was one leg blocked, another leg not. But anyhow, we went as usual. So we gave, you see, one induction, 100, and then when we put a tube, another 100. So it was more or less same case. We did the block. And then I need to say that the blocks were being done by me and one of my colleagues, but anesthetists managing cases, they've been differently. So they use their expert judgment how to manage patient. So it was given another 150 on skin incision, sternotomy a bit, and then probably anesthetist thought that he gave not too much. So he gave another 175 on aorta cannulation. So saying just about how patient felt after extubation, you see here a pain score is 5 on extubation and 5 on 4 hours after. But looking better dynamically, how we use and how we managed, I'll show you this slide, which looks a bit busy, but I'll help you to surf. It's nothing difficult. So you see on induction, patient came with systolic pressure 144. Then it was induced with this medication on left side, midas, propofol, and Sevo, bis 48. So we proceed for intubation. Patient picked up his NOL index, and we gave another 100. So he dropped down and he was comfy, but when we insert TOE and we did a CVC line, patient showed some sympathetic reaction, which was very short, wasn't treated from our side like a pain, so it was just some spikes and very short them. Then we did a block. When you put a needle on patient, you see patient has a blood pressure quite comfortable, much less than when he arrived. So if you look on blood pressure, so it doesn't look like he needs something. Yeah, he was quite comfy. And anyhow, his nociception NOL index came up, but again, just a spike. Very interesting here when we see this red arrow and P, so this positioning. So when we lift legs up and position patient, so he showed again some kind of sympathetic reaction, very short, very fluctuating, not treated as a pain from our side. So when we start on skin incision and chest incision, so blood pressure, if you pay attention, 120 systolic, so it's less than on induction, so it looks like you shouldn't touch this patient with nothing, but NOL confirmed that he probably have some pain, and anesthetist anyhow, he preferred to give 150 of fentanyl. Then it's coming sternotomy, and it was given a bit of fentanyl as well, because NOL showed that might be a bit of necessary. It was, as I said, expert judgment. So an aorta cannulation, as you know, in cardiac surgery, we try to keep blood pressure a bit lower, and it was a tradition to give altogether something, but opioids as well. So patient had a good dose of fentanyl, and it was quite comfy, and then patient has just some spikes of NOL, but NOL index, but not major, not thinking about pain. So as I said, this patient had much less than previous one as an example. So totally plus infusion what we had in intraoperatively until going to bypass, patient had 800 micrograms, which is less, let's say 30-40% than just a classic approach. Always he was in a range with a BIS. And if you look statistically here, we have a statistic analysis of patient of NOL index, and it was 77% was 25 and less. So patient was quite comfy, I think. So, and pain score showed us that patient was okay. So second patient is a cabbage-free grafts, 70 years old gentleman with a good ventricle, same timing, and same on top we have a classic example, as I said. On the bottom here we have this case where we gave on induction plus tube 300 fentanyl. We did a block, and on skin incision this patient had just 100 fentanyl. Then on sternotomy, he didn't have anything, and an aortic cannulation occurred. If you look on a cumulative dose before going to bypass, patient had 600 micrograms, which is twice less than a classic approach will say. And if you look dynamically here, again, patient, it was a bit different picture, came with a bit low pressure, but on induction, he increased a bit blood pressure, and on intubation, even pressure jumped to 170 systolic. So he had totally 300, and he dropped his NOL index on very, very low level. Even when you insert CVC lines, it was okay, no response. But when you put a TOE probe, patient has a bit of peaks a bit. His NOL index in blood pressure at that moment was quite stable, and we went further. So you see this case, it's finished as well under well control with a small dose of opioids. So in post-op, he had just a 5 score of. So this case is mitral valve redo. He had 1 year ago STEMI and cabbage. Came with us infective endocarditis with severe MR. So he went for another surgery, good ventricle. And if you see here, he used very small dose, just 315 fentanyl. When you look on dynamics here, he had some small spikes. Blood pressure was okay, no inotropes, and totally going to bypass, he had just 300 of fentanyl. In post-op, he had another 150. He had specifically here on wires, guided by NOL. So you see, we gave precisely dosages depending on how he is behaving. In first day, when he was on PCI, in 15 hours, first 15 hours, he just took 1.5 bolus of fentanyl, and then just 1 bolus. And in 1 day after, he refused to use anymore. So we did 72 hours after recovery quality to check. So patient had a score 9 from 8, and for pain 9 from 2. So patient was very comfortable. If you compare for cabbage's patient now the dose, average dose, so you see it's a half of what we use comparing the traditional approach, and hemodynamically blood pressure and heart rate was in a good range, so not compromising anyhow. So statistically it looks very nice as well. So what we found that the NOL monitoring is helping us to manage, to identify and to manage pain, and to give correctly analgesia, which is improving the patient safety and is keeping the anesthetist very confident. This is our conclusion, which is saying that NOL monitoring is helping to personalize analgesic titration, keeping patients safe. Combination of deep parasternal block is facilitate an adjustment of opioid doses and to reduce intraoperative opioid consumption, as well as I mentioned already. So NOL monitoring is helping us to keep patients safe and to ensure anesthetic confidence. Thank you very much.
Thank you very much, Dr. Perciun. I think our audience would like to listen to the next talk also. That will be presented by Dr. Andrea Ambrosoli from the Varese of Italy. So if you could please stop sharing your slides, Andrei, so that Andrea can share his. Meanwhile, I would like to inform everybody that we have a diverse audience. So please feel free to share your thoughts, your questions, your comments, that we could facilitate our discussion at the end. So, Andrea, the microphone to you.
Thanks a lot, Professor Moka. Good afternoon, everybody. I am Andrea Ambrosoli, and I'm the Director of Anesthesia in a maternal and pediatric hospital in Varese in the north of Italy. I'd like to thank the organizers, Rachel and Fabio for medicines, and my colleagues, Eleni and Andrei. I apologize for my voice, but as long as I daily work in pediatric ward, it's normal for me to have a flu, as I told before, 10 months a year, more or less. Now I share with you a couple of videos. Okay. So I'm trying to share the right things. Okay, perfect. I want to talk, about a case of gynecological surgery and a couple of cases of pediatric surgery. Professor Moka has already well explained the whole state of art.
Andrea, have you shared your slides or not yet?
Yes, I have. Yes, no, it should be shared.
Now it is on.
Is it good? Perfect. Professor Moka, thank you, Eleni. As already well explained, I was saying the state of the art about nociception and local regional anesthesia. It's my turn now, and what I want to show you really is how we use it in everyday practice. I hope we will appreciate it because the film sequences are captured live with no erase or redo, so we can see really what happens in reality. In my hospital, we usually normally use NOL, principally to check our local regional anesthesia if it works and if our opioid dosages are right. We check all the correlation between these parameters and postoperative pain. So I start. I hope you will see. The first case is about a 54 years old woman scheduled for bilateral adnexectomy for right ovarian cyst. Regarding past medical history, she suffered from breast cancer treated with left scotrectomy plus chemotherapy. She's on single drug therapy for hypertension and a smoker. So in class 2 as you can see, general anesthesia induction is performed with propofol and remifentanil TCI using the elevated model, BIS, last type of model, and non-monitoring. Endotracheal intubation is obtained, anesthesia maintenance is managed with remifentanil and propofol TCI. We use normally 4 milligrams dexamethasone, and we do, as you can see from the video, bilateral ultrasound guided tab block with 0.25% levobupivacaine, 20 ml per side. As we can see here, tab blocks are left and up to the right side are practiced without no variation over 20. After our initial part, there is a surgical preparation for adnexectomy, and as you can see, NOL index more than 25 for longer than 2 minutes, likely requiring an increase in opioid dosage. We normally use a remifentanil effect site concentration of 4. So we use TCI with 4 as an index. And here you can see what I was showing before. And that block has not probably yet taken effect, as too little time really passed since its execution. After good adaptation of opioid dosage, we can watch adnexal extraction. NOL especially being below 25, exceeding it for a maximum of 2 minutes. So as you can see by the videos, now the NOL wasn't clinically significant. The rise means that there is a particularly painful surgical maneuver. You see NOL now is 41. You can see the adnexal extraction by our surgeon, and depth of anesthesia remain adequate. As you see, the BIS is more or less for about 40. So it means that our surgical maneuver is really painful, and we adapt again our remifentanil dosage to what is happening really. You see now the part. Moving forward, there is hemostasis, well done before closure. Our normal anesthesia consists of paracetamol 1 gram, ketorolac 30 milligrams, ondansetron 4 milligrams, and dexamethasone 4 milligrams. Analgesia and depth of general anesthesia are adequate according to NOL and BIS, as you can see. And now, finally, surgical closure. We administer morphine 2 milligrams intravenous, mainly to facilitate the transition and discontinuation from remifentanil. NOL is adequate, this is adequate. Remifentanil concentration effect is reduced to 2 to start lightening of anesthesia. There is a smooth awakening and extubation with concentration remifentanil 2 ongoing and suspension of propofol. The patient after this surgery reports no pain and no further analgesics are required. So this is what really I wanted to show you, because there are many things that can be said about this kind of video. I'm open to any kind of question you have after my speech. And now we switch to pediatric cases where we normally use NOL in the same way. No differences between pediatrics and adult use. So the first clinical case concerns about a 3-year-old kid, male, scheduled for right orchidopexy with no anamnestic data, born at term, no medical conditions. So class 1 ASA. Normal anesthesia plan is induction and maintenance with sevoflurane, LMA, and ileoinguinal block with levobupivacaine. During induction, you can see a little rising of NOL, and effectively NOL increases only during LMA positioning. You see NOL 29 with after positioning a rapid decrease. Now it's still the moment of position of LMA, and there's a rapid decrease after finishing the induction procedure. So this shows that our anesthesia plan is right. LMA is fixed and NOL index is below 20. I want to stress really a simple placement of LMA. I think that everybody knows that we can do it 20 times a day. Can be so painful, so allergic, so the NOL moves above 20. Probably we should be even more soft here. And NOL really help us in learning how to improve our maneuvers, how to do them thinking about the patient and what really happens, because we were blind before seeing this. As you can see now, the NOL is under 20, and it keeps maintaining this kind of number of kind of index. Then after LMA positioning, mechanical ventilation is obtained before practicing regional blocks. You see now again, I want to stress this thing. The only moment is when LMA is positioned. Orchidopexy is managed with both inguinal and scrotal incision. So we use 2 separate blocks, both dental and ileoinguinal hypogastric block. We use enhanced visibility needle, 22 gauge for 50 millimeters length, to obtain ultrasound guided dental block with 4 ml of 0.25% levobupivacaine, and the ultrasound guided ileoinguinal block and hypogastric block with 6 ml, 6 ml in this case, 0.25% levobupivacaine. As you can see, block are performed without great variation of NOL index. So this means that our technique is minimally invasive, and this is a plus in regional anesthesia. It was worse positioning an LMA rather than having a regional anesthesia done. So even in our block procedure that lasts more than 2 minutes, there is a NOL index that comfort us in our thoughts. In pediatric practice, really NOL may play an important role in what is determining whether regional anesthesia is actually working. So to enable us to give, to safely lighten general anesthesia, to give the right general anesthesia in a population that deserves particular protection. Surgical incision starts 5 minutes after peripheral block execution. probably too early, and we can see it again by looking at NOL. In fact, NOL rapidly increases during first cutaneous stimulation, and we adjust opioid management. During procedure, NOL decreases, vital parameters and anesthesia depth remains stable. LMA is removed spontaneously in spontaneous breathing, maintaining an adequate sedation, and the awakening is smooth with an extubation, always with remifentanil set 2, with an effect concentration of 2, and suspension of propofol. We use FLAC and KEOPS scale to see if there is some kind of pain in the recovery room for our babies, and I can assure you that all the scale was good. So the patient went to surgical ward without any problems. The second pediatric case is concerns about an 18-month-old kid. So you can see all smaller than the one before. Male, scheduled for bilateral laparoscopic orchidopexy. Non-amnestic data also in these cases. We are used to have non-amnestic data because babies normally don't have any amnestic data. Born at term, no familial medical conditions, class as a 1. We practice induction with sevoflurane to obtain peripheral vascular access, and then maintenance is performed with TCI. As you can see, we use TCI with everyone, from the adults to the babies. Propofol 1% and remifentanil 20 micrograms per ml, so pediatric use, using always elevated model. BIS and NOL are monitored, and as we expect, NOL increases during intubation. You can see 31 until 57, notwithstanding the use of the video laryngoscope. You've seen that we always use video laryngoscope also in babies. After intubation, ultrasound-assisted caudal block is performed with levobupivacaine 0.25%, 10 ml, with 22, it was black one, so the 22 gauge caudal needle without NOL increasing. BIS is in a good range, so we have a good management of pain in this specific block. Injection of local anesthetic in the caudal space doesn't make NOL index increase. Now, you can check it because we done it. This is the puncture, and there is now the injection of local anesthetic, and it doesn't make NOL index increase. And this is a good sign for us because we learn from NOL that when caudal, the needle is in the right caudal place, there is no rising in NOL, while BIS remains about from 40 to 50, if I can remember right. And while we are injecting the caudal space, there is no variation in NOL. We use ultrasound just to check if we are in the right place, but NOL is another kind of thing that help us, as I told you, checking the right, if we are in the right place. NOL, we use NOL even in small children. You see, you can see that we have never problems with the finger probe because we put two fingers together with the probe, and there is a high reliability in the signal. So you can see that the wave is good, the number is right, and we use it every day in our daily practice, really. After blocks are performed, surgery starts, and you see NOL that you can see NOL that remains stable during the whole procedure. This is a laparoscopic procedure, so you can see that it's a tough procedure. BIS maintains 42 UCN and NOL under 20. Smooth awakening and proper extubation with remifentanil ongoing, and we suspend propofol in the good management. So we maintain deep sedation and spontaneous breathing. Vital parameters in BIS remains stable and adequate. So we have a good way of awaking really babies. I finished the videos. What I want to I interrupt the contribution so I can. I think now it's not sharing. Okay. I have only 1 minute. I want to tell you more or less what I wanted to show. The nociception level index helps us to determine really whether and at what point regional anesthesia provided effective analgesia. In shock procedures, the energetic contribution of, for example, a tap level bupivacaine block is typically emerges during the second half of surgery because it takes time to reach the good concentration and the time to level bupivacaine to act. NOL guided management allowed us to administer a good, a suitable lower doses of morphine, and it changed with or without NOL. We use different kind of dosage with or without NOL. So in the context of TIVA, for example, with TCI, bis alone offers a very important but sometimes incomplete view. Combining bis with NOL, in our context, in our opinion, enhances interpretive assessment and optimizes analgesic titration. And this consideration both in pediatric and adult use are the same. Most of all, in pediatric practice, NOL may play really an important role and also valuable for verifying, as I told you, a cauda block, a good regional block. NOL has now an MDR approval, so you can use NOL in pediatric surgery, and there is a lot of validation now. Apart from myself, that I can assure that it's all good, but there is also many papers that validate pediatric use with NOL index.
Thank you, Andrea. Thank you. We have a couple of questions in the Q&A. We try to reply online, but there is a question for Andrei regarding the duration of analgesia of a deep parasternal block, a single shot block. A question that was given by a very good friend of mine, Kamen Vlasakov from the United States.
Yeah, I answered already anyhow online, but I will say that on parasternal block, it's, well, we can see that it's working well. Our patient is quite comfortable and NOL is confirming that. And pain score after operation, it's quite good, it's encouraging. And they use a very small dose of opioids in post-op and patient very comfy. But saying about anyhow, generally about interfacial block on chest, what we noticed on the thoracic surgery, because on parasternal now is difficult, patient anyhow we have some opioids, how long it's working, it's working, but comparing with thoracic, we noticed that these interfacial blocks are working like 3.5, 4 hours, like a full power, because washout on chest is quite strong and intercostal nerve are not so big like on limbs to absorb and to keep this this power of being numbed. So I'll say that, and again, it depends, you want a level of pain control or you want an anesthetic level, so it's a bit different. When we speak about anesthetic level and the concentration and volume we give for surgery, what we've seen that it's working very well around 3.5 hours. And then anyhow, we need to load them at the end of surgery in thoracic with some opioids to keep them comfy, or we put a catheter and we go for like infusion or boluses via PVB or a rectus spine, for instance. That's why about parasternal exactly, I can't tell you exactly, but having this knowledge that the interfacial block will work this time frame, the point for us is to do a block at the beginning and to cut off partially bigger or smaller of this strong pain of incision and the sternotomy, traction, retraction, I mean, and everything. So this will create a better environment and better will protect somehow probably our brain from this strong trigger, which can cause a kind of a persistent post-surgical pain, or you need a huge dose of opioids. What we've seen doing this block, being guided by NOL, we can give very, very reasonable dose of opioids. Patients are comfortable. They don't feel so strong pain after. And it looks clinically, it looks very well, to be honest.
Thank you, Andrei. There were other questions about the existence of randomized trials, and I would like to say my opinion. Yes, there are some trials comparing the standard of care versus the utilization of NOL index. But what all authors conclude is because it is impossible via a small RCT to have definite results, let's say, probably it's needed to do multi-center trials so that there is a need of multiple institutions to get together and organize a nice protocol with the utilization of NOL index involving higher number of patients so that we can get some meaningful results. I don't know if, Andrea, you would like to say something as a take-home message.
Take-home message. I use NOL in every kind of patient I have. So I've in few months, in 6 months, I have a great experience. And what I have to say is that I showed you in real time what my resident do every day. They put NOL. They see what happens. They see if there is a problem with the LMA positioning, the problem with intubation. The intubation, we are really soft. But anyway, in any intubation, you see the NOL as a peak. So we have to check if it's correct what we do for intubation, or if we have to intubate anyway. The local regional anesthesia is less painful than intubation, but really less painful. I showed you while we are doing a local regional anesthesia, the NOL is about 0 or more or less, anyway under 20. So NOL means learning how you practice every day. If you do a good regional anesthesia, if your anesthesia is complete, and in my opinion, having a good analgesia plan during the surgery means really a good anesthesia, a good analgesia also after the surgery, because we know when we have to give, for example, morphine, or we have to increase dosages of opioids or anything else we need, or if our local regional anesthesia didn't work. So if it didn't work during the surgery, it means it will not work even after surgery. And you teach me this, Eleni. You always say that if it works from the beginning. If it doesn't work from the beginning, you have to check why. And so we see that levobupivacaine, for example, that block takes more or less 10, 15, 30 minutes to have a real good plan. While if we do it with other anesthetic, local anesthetic is more, it's faster, So I can say, use it and check if it's all right, what you do or what you always did.
Exactly.
We changed a lot. We learned, we improved a lot.
This is my opinion too, that the monitoring can help us titrate, verify, confirm the efficacy of what we were doing until now, because we always used regional analgesia techniques. We were always using adjuvants to somehow improve the analgesia offered to the patients. There is another question for Andrei. How about inserting a catheter for continuous analgesia for central blocks? I don't know, Andrei, if you would like to reply to that.
Central blocks, you mean spinal catheter?
A catheter for sternal blocks, sorry.
For parasternal blocks. Yeah, it exists. I know it exists. Some hospital they started to use parasternal catheter, which I think it's a probably a good idea. We don't have this experience just because this implies some infrastructure, some logistic stuff. And to be honest, I know about one hospital who did a great job, and not parasternal, but generally for regional. So it took 2 years for them to put a system in place. So speaking now about generally speaking, it's a big effort, to be honest. And that's one thing. Second thing, if you compare benefits, again, it depends, because what I've seen of even single shot patients, they are comparing with previous our experience, they are much better. This regional anesthesia really contributed to help them from point of view of pain. Now I can't tell an answer that if you put a catheter will be better or not. It should be kind of comparative study, for instance, to see where we go. But to be honest, even on this stage of things, I'm already happier than I was before, because I see that patients are much more comfortable in our approach based on regional and based on NOL. It's more intelligent, let's say.
Yes, exactly. And we have a very nice comment from one of our colleagues attending who is using the NOL index since 23 for a couple of years for a multimodal and opioid-free anesthesia setting. And I fully agree with our colleague that it is very important to discuss about this monitoring. You're absolutely right, because it's a real key and maybe the future to balance and to modulate the autonomic nervous system responses, and NOL can be a key in these efforts. Also, another colleague wrote that it complements objectively measuring pain. Exactly. This is the truth. And of course, we can have benefits that can be documented for our patients, for our hospitals, for the healthcare providers, for the healthcare systems, because at the net end, what we want is fast-tracking our patients, having enhanced recovery after surgery, and pain is an important parameter that is, if it is controlled, it can facilitate the outcomes of these strategies. There are a couple of other questions, I think. Again, about the catheters and the blocks, the parasternal blocks. What about using Exparel instead of the classical local anesthetics? Have you used them? Have you used it, Andrei, in your practice? The liposomal bupivacaine that lasts for about 2-3 days.
No, unfortunately, we don't have this. No, unfortunately, we don't have. This we use Levo for now. So yeah, sorry, but we don't have this experience.
In theory, at least, because I don't have it in my country, in theory, it seems that it could be another option, but
yeah,
you need them to be. This medicine does not is not circulated in all countries, at least to my knowledge, in all countries in Europe. So that's why we don't have experience. But if we have it in our hands, I'm sure we can start utilizing it. Any key message from your side, Andrei, because we are around to closing the session?
Well, I will say that it was an opinion that probably kind of monitoring of pain monitoring in cardiac surgery doesn't have place, because we give a lot of opioids and things. We put patient very deep. But currently, based on ERA's principles and based off this experience what we have, I think that nociception monitoring is exactly the place in cardiac surgery which we should use it, because we can really not just write that we should use a judicious dose. We will see how much we need to use. We will be very precise. And if you combine with regional anesthesia, in our case, for instance, I think we give completely different anesthetics now. So I will support the idea of nociception monitoring in cardiac surgery. I think it's exactly the place where we need to use it, in fact.
Okay, and I would like, first of all, to congratulate both of you for the excellent presentations, very comprehensive, very live, and very close to our clinical practice. I would also like to thank the audience for being with us and becoming interactive via the Q&A chat box. My take-home message for all of you, for all of us, is yes, NOL is a very, very useful monitoring that helps us through the AI algorithms that are integrated into the machine to titrate what medicines we give, what analgesics we give, and to somehow make our practice in the model of precision medicine, meaning analgesia tailored to the needs of the patient, to the individualized needs of our surgical population, according also to the surgical procedure that is applied. And by this message, I would like to thank you all once more. And why not in the future meet again and discuss the same topic? Thank you and congratulations. Have all a good day or a good evening, depending on which part of the world you have been set to attend us.
Thank you, Eleni.
Thank you to everyone.